mención. Dale.
Okay. Well, good morning, everybody. So we are going to talk about this topic, Staphylococcus aureus methicillin resistant, with my partner here, Andrea Layedra. My name is Roberto LEGUIZAMON. Next one, please.
Okay. Regarding the main contents of this topic are microbiological characteristics, which includes taxonomy, morphology, and habitat, cultural characteristics, and virulence factors. The second one is infection mechanisms and pathologies, prevalent clones and treatment, and finally a matter of concern, which includes mechanisms of developing resistance and high-level resistance to methicillin. Microbiological characteristics. Staphylococcus aureus belongs to the Staphylococcaceae family, genus Staphylococcus, and species Staphylococcus aureus. It's a gram-positive catalase-positive coccus. Its diameter is of 0.5 to 1 micrometer. It has a cell wall very thick peptidoglycan layer due to this gram-positive bacteria. It is non-flagellated and not motile, and it doesn't not form spores. It is encapsulated, and this bacteria reproduce by binary fission, and complete separations of the daughter cells is mediated by autolysis. In this absence, the daughter cells remain attached to one another and appears as clusters of cells appearing as characteristic branches of cells. Regarding the habitat of this bacteria, it appears in mammalian body surface, normal flora of skin and mucous membranes, and it is present in nose anterior nerves, and enterogenic strains are found in various food products. Regarding cultural characteristics, Staphylococcus aureus grow in almost bacteriological media under aerobic or microaerophilic conditions. Colonies in solid media are found smooth, raised, and glistening. And to identify Staphylococcus aureus, the following agar media are used. Mannitol salt agar, in which the bacteria appear circular of 2 to 3 millimeters with a smooth and shiny surface, and the colonies appear opaque and are often pigmented golden yellow. In tryptic soy agar, they appear circular, convex, and entire margin. In blood agar, show beta hemolysis, and in brain hair infusion agar, form yellow pigment colonies. Infection mechanisms and pathologies. Staphylococcus aureus express many potential virulence factors, such as surface protein that promote colonization of host tissues. Invasins that promote bacterial spread in tissues. Surface factors that inhibit phagocytic engulfment. Biochemical properties that enhance their survival in phagocytes. Immunological diseases such as protein A, coagulose, and the membrane damaging toxins that lyse eukaryotic cell membranes, such as hemolysins, leukotoxins, and leukocidin. Exotoxins that damage host tissues or provoke symptoms of disease, and inherent and acquired resistance to antimicrobial agents. The mechanisms of Staphylococcus infection You can see in this figure, in the first part, bacteria obtain access to sterile tissues via open bones and use adhesive proteins such as fibronectin binding proteins, clumping factor A, and collagen adhesives for a specific attachment to extracellular matrix protein. These bacteria can also in part regulate morphonuclear leukocyte influx in subtle ways involving activators and inhibitors. And the polymorphonuclear leukocyte peptides promote the release of pro-inflammatory lipoproteins, which are active toll-like receptor 2 and contribute to local inflammation. And Staphylococcus aureus produce coagulase to polymerize fibrin and form and encapsulate abscess around the infection site. These bacteria can also comprise effective opsonization via antibodies using a polysaccharidase microcapsule and surface protein. And the abscess can release live bacteria to the surface of the skin and or bloodstream at later stage that a plasminogen activating protein might contribute to bacteria dissemination. Regarding the pathologies, human staphylococcal infections are frequent, but usually remain localized at the portal of entry by the normal host defenses. And the portal may be a hair follicle or respiratory tract. And the localized host response to this infection is inflammation characterized by an elevated temperature at the site, swelling, the accumulation of pus, and necrosis of tissue. Localized infection of the bone is called osteomyelitis. Serious consequences of Staphylococcus infection occur when the bacteria invade the bloodstream. Resulting septicemia may be fatal. Bacteremia may result in seeding other internal abscess, other skin lesions or infection in the lung, kidney, heart, skeletal muscle, or meninges.
Okay, well, now we are going to talk about prevalent clones. Prevalent clones. Well, although there are many clones distributed around the world, there are some specific that are very important in order regarding, for example, virulence or frequency of outbreaks. So yes, in South America, we have this strain USA 1100 and USA 300 LA that belongs to the CA-MRSA, that stands for community-associated methicillin-resistant Staphylococcus aureus. Those ones are the prevalent clones. Yes, that we are talking about clones here, not strains, sorry. The predominant in North America, it's the USA 300 sequence type 8, 4, and that's also another CA. Predominant in Europe clone is the sequence type 84. In Asia and in Africa, for some reason there is not enough information, or the heterogeneity, it makes it difficult, but in both cases they are not identified a specific prevalent clone. And what I wanted to add here is this CA and HA that we are also going to talk about later, but community associated, and HA stands for healthcare associated. Next one, please. Here, for example, well, another examples of these prevalent clones, we have two other groups that it's important to mention, this EMRSA 15 and 16. And those one, for example, the first one is CA, community associated, sorry, and the last one, healthcare associated. What's is important to say about this is that the HA shows like more complex or more worrying cases, since this present more these clones present more resistant to more antibiotics than the CA. So that's the worrying situation here. So, well, these clones are part of the epidemic methicillin-resistant Staphylococcus aureus lineage prevalent in the United Kingdom. And the other example is the sequence type 239. It's another also HA methicillin-resistant Staphylococcus aureus. Okay, this is one that it's the most widespread in multi-drug resistant clone globally. That's the one that is prevalent in the world. Next one, please. So how we treat that? The treatment, well, of course, there's not a specific treatment for all Staphylococcus aureus methicillin resistant. So first of all, yes, there are three main features that we have to look at. For example, infection site, where is it? The severity of the infection, and of course, always the antibiotic susceptibility test of that strain involved. It will depend on that, on the treatment. That is specific the therapy. I mean, the other ones, yes, could give you, but the AST, the antibiotic susceptibility test, will give you the information, the specific information regarding the drug therapy. And in the next slide, here, for example, we can see the how we can attack this virus. You can notice that there are plenty of targets. For example, the cell wall, in the cell membrane, cell wall and membrane, DNA, RNA synthesis, protein synthesis, okay, folate synthesis. Yes, also, well, we have different steps where the folate synthesis can be inhibited, or yes, or also in the protein synthesis. So there are a lot of drug therapy, because there are a lot of targets for this Staphylococcus aureus, but the ones that are more used to now are more, yes, are in the practice nowadays is linezolid, vancomycin, linezolid. For example, those ones are the most used. Well, we can see existing antibiotics options are in green, and new antibiotics approved and on the market are in blue, and the antibiotics in the pipeline are in orange. Daptomycin is another example, for example, for the cell membrane. Next one, please. Additional treatment. Well, this is regarding the non drug therapy treatment. Let's say how we manage with this situation. Incision and drainage for localized skin and soft tissue infection, such as abscess or balls. The primary treatment is often incision and drain. This procedure involves making an incision to drain pus and infected material from the site. Wound care. Proper wound care is important to prevent the spread of infection and promote healing. This may involve cleaning the affected area with antiseptic solution and dressing the wound appropriately. Supportive measures in severe cases or when the infection has spread to the parts of the body, additional supportive measures may be required. This can include intravenous fluid, pain management, and supportive therapy as needed. Yes, next one, please. Well, here I'm going to talk about mechanism on developing resistance. Methicillin resistance in Staphylococcus aureus is primarily attributed to the acquisition of MEC A or C gene, which encodes for unique penicillin binding protein PVP2A or PVP2C, those ones that are peptidoglycan transpeptidases. 12 known Staphylococcus cassette chromosome MEC types from 1 to 12 have been identified and classified according to the type of cassette chromosome recombinance complex and the class of MEC complex. So this is about the gene or the cassette of genes that codifies for this PVP that is involved in the peptidoglycan synthesis for this microorganism. Yes, next one, please. So how the bacteria develop resistance? Okay, as we have seen during the course, there's could be and in this case, for example, the reduce in the affinity for this PVP to the beta-lactams antibiotic. That happen, for example, more often in the healthcare methicillin resistant and Staphylococcus aureus, that shows more like a profile of inhibitor, like the the antibiotics, the beta-lactams antibiotic doesn't have more of them, of this group doesn't have an effect on these clones. So yes, what happened that the virus is allowed to survive and grow in presence of these drugs. And the SCC MEC elements carry also in these genes, carry also another genes that regulates the expression of the MEC A. Next one, please. Well, also, there's no, we have seen also that there are combinations of multiple mechanisms of developing resistance, not only in the reduction in the affinity from PVP to antibiotics, but also, for example, beta-lactamases production. Not all of the strains produce this beta-lactamase, but there are some cases that they do. So they have two mechanisms acting together, exerting their action together. So it's like a synergy of, or how they are surviving through these two mechanisms, beta-lactamases and reducing the affinity of PVPs. Next one, please. Well, it's important to know that the mechanism of resistance can vary among different strains. That's what I said before. And there's also, well, I also said that the treatment involves vancomycin and also linezolid. And for example, in Japan, there was cases of vancomycin resistance, and that this microorganism was called vancomycin intermediate resistant Staphylococcus aureus, this VISA clones, strains, sorry. And yes, also, well, in Buenos Aires here, there was reported a case of linezolid resistance. This is the reason why the AST is very important to establish a drug therapy, because we can have this. And what they said, what I read about these cases, is that they were, of course, they were developed during the time of the patient in the hospital. So it was during the treatment of these antibiotics, the microorganisms develop this resistance. So this is also what we have been talking during these 2 weeks in the course. Once you introduce an antibiotic, the microorganism will manage to develop resistance against that. And that happened in the Hospital de Clínicas. Next one, please. Well, here, high-level resistance to methicillin. MRSA epidemiology is changing rapidly due to the continuous development of clones. the efficient therapeutic management of infectious diseases through automedication, the lowly restricted sales of antibiotics in pharmacies, as well as medical prescribing practices without a laboratory investigation, contribute to the development of new MRSA clones with increased resistance to antibiotics. Multi-drug resistant phenotypes are emerging. This is also to conclude or to say yes, to give this like an end. Once you introduce an antibiotic, new development of resistance, mechanism of resistance against that. Well, also the contribution of the low restriction of that antibiotics in the pharmacies, the bad practice of not doing an AST could of course not good. It helped a lot to this new development of clones and the resistance, and that because of all of this, the multi-drug resistant phenotypes are emerging. Next one, please. The knowledge of clones allows studying antibiotic resistance spectrum for each one, a fact of great importance for medical practice. Appropriate prevention, risk factor, and natural history of staphylococcal infection are not fully elucidated. Therefore, it is necessary to monitor antibiotic resistance, judicious organization and of antibiotics prescription and therapy of infection contagious disease, medical education of travelers and immigrants. So this is like also to make the community to be conscious about the use of antibiotics, and also the surveillance, like for example Malbram-2, that's through the new emerging of new clones or the most prevalent strains. So yes, that's why it's so important to do that, because we are like following on which antibiotic resistant expectant this specific microorganism has. Next one, please. And yes, well, this is our bibliography we used, and we say thank you for your attention, and well, have a nice day. Bye-bye.